better. You all can hear me okay, right?
Mm-hmm.
Awesome. So, welcome to Climate Health Now's first ever evening meeting. There's a lot of different feelings about the evening meeting, but we're giving it a try because we want as many people as possible to be able to participate in our events. So this is a pilot. So if you want to share feedback, we'd be open to that. But my name's Ashley McClure. I'm one of the co-founders and co-directors now of Climate Health Now, and I'm excited that you all are joining. So we have a really exciting hour ahead. So the theme of this month and this hour is all about healthcare's climate pollution, mapping it, measuring it, and working together to reduce it. That's what we do best, is the collaborative part about making change. So thank you for being here. And there's really no words are sufficient, but we just want to acknowledge the human suffering that's going on right now in Israel, and this, I don't know, it's tragic, and just want to acknowledge that, having no solutions, no answers, obviously, but it's a really hard time for a lot of people. So acknowledging that. And we always start with our North Star, which is our mission. And our mission in Climate Health Now is to organize and mobilize the California health community to advocate for equitable systems level climate action. And we're really excited that you all are with us. And just to reiterate and underline, the California health community is super inclusive of anybody who self-identifies as being part of the health community. So I've invited my medical assistants, our health administrators, our public health colleagues, our dentists, our therapists, our nurses, our doctors, everybody. So we need the biggest tent possible, and so that's who we invite to be our members. So the kind of outline for our time together before dinner is we're going to welcome new members. We're going to hear from Lori about her work to get her health system to sign on to the Human Health and Services Healthcare Climate Pledge, and how she did that, taking notes on her leadership. And then we will hear from Dr. Bill Pevick, who is our one of our healthcare sustainability resource team co-leads. Then we'll talk about the Sustainability Fellowship that Climate Health Now is launching, and invite you to consider applying or share it with all the people you know who might be interested. And then we'll close up by 6:30 because I'm in clinic and the fire alarm is going off. A test is going off at 6:30, so we will finish promptly before that happens. Okay, I'm gonna skip that. So we're gonna go straight to Lori. The floor is yours, and we'd love to hear the story of how you led for change.
Okay, well, I credit my start in climate and health with you and Amanda, Ashley, and a spot I heard on NPR back last spring about how this was our way in as healthcare providers to being able to have a role in climate and health, because I was looking for a role. And I heard about the pledge through Climate Health and through Bill Pevick, and I thought, wow, sounds so cool, sounds so important, but what can I do? I could send a letter to my CEO and it would be, I mean, maybe I wouldn't even get a thank you so much from it. And so that I had to sort of think about how I could be bigger than just me. And part of that journey was talking to people, talking to people in my division, talking to my department chair, starting the conversation with, oh my gosh, I just heard the statistic that US healthcare is responsible for 8 to 10% of US greenhouse gas emissions. Is that crazy or what? Like, can you even believe that? And what can we do about it? I asked for some advice from friends who are department chairs, asked for advice from people at Climate Health, including Bill Pevick, and ultimately found some champions who thought, wow, I never knew that this was such a big issue, and absolutely we should do something, and maybe we should do something at the medical staff level. And hey, would you want to come talk with the department chairs at our main hospital? How about, do you want to talk to our department chairs at our sister hospitals? And, of course, I'm nervous about that. I've never given a climate talk. Thinking, I think I heard that it can cause preterm labor if you're exposed to PM 2.5, but I don't know anything. So not quite fake it till you make it, but a little bit of that feeling. And take those presentation opportunities if they are offered to you. And again, reach out for some help for people who have been on the road before to help you think about what you're going to say and develop some slides. And then we got even a little greedier, now that I had some people thinking that this was a good idea. How about we don't just go with 10 signatures? How about we go with 300 signatures? And so that's where the idea came to do a petition. I had never done a Google form before. Like, I was thinking about how can I do a petition? And of course, I have kids who are in their 20s who said, "Oh, Mom, Google form. Have you never heard of a Google form?" So now I have, and now I can do a Google form. And we got over 360 signatures, which, that was really the entry point to having a pitch to leadership. Because, we sent the letter about all the importance of climate change to the health of our community and to our ability to have continuous operations at our hospital in the face of heat waves that cause power outages, and did so at our very own hospital last fall. And then introduced the idea of the pledge and how great it would be if we could sign on as a health community. I work at a county hospital. Our motto is better health for all. And so with those 360 signatures, I was offered the opportunity to meet with our CEO and CMO and associate CMO. And next slide is fine.
Love this.
Yeah.
Love this.
Okay. And so, one piece of advice that I had also gotten from Bill is, what's in it for them? Because I think we all have that very righteous and passionate feeling, that we need to save the world and we need to do no harm and the time is now. And those messages are super important. But that little icon up top says, okay, yeah, next. That depending on who you're talking to, and that's one thing that I've learned over this year, that you pitch the message a little differently. So not that these things aren't important, that I did mention those things to our leadership, but the idea was to align it with what's in it for them. And that is the organizational priorities like equity, equality, safety, and especially cost savings and loss avoidance. If we go down with the power grid, or the flood, and we don't have a climate resilience plan, we're going to lose money. So those things really helped. And I also talked about things like marketing and reputation. I talked about the IRA funding opportunities. I talked about the TJC sustainability certification, and down at the bottom, that's a link to that. And we talked about our county, a larger county, actually has a very ambitious sustainability plan, and that we should try to align with that. What I was hoping for was just a interesting, we can continue the conversation, but what I got was, okay, we'll sign, which was beyond my expectation. Sorry. I think one thing I've heard from another hospital, New York Presbyterian, is they were not able to get their pledge through, but they're going to try to get through a commitment to the Sustainable Healthcare Certification Program through the Joint Commission. And so I suggest that people look that up just to see if that's something that might work for them, because it is something that is a little more achievable, I think. Are you measuring your waste? Are you measuring your energy? It's not quite as big as the pledge. So that's all I have.
Amazing. Woohoo. Yeah, and that you were expecting just to discuss, but the success like came kind of surprisingly early.
Yeah.
Rare
Yeah.
and special.
Yep. So now I'm acting as a citizen champion at our institution, along with a member of the executive team, and we're trying to make this work.
Oh,
Yeah.
wonderful. I know you're in high demand in general, and especially tonight. Does anybody have a question or two before she has to jump off? Grassrootsy approach for sure, Alana. And I
Yep.
love that you like learned how to use a Google form and like this carried forward to now you're meeting with the executive team.
Yeah.
That's fantastic. Yeah.
All right.
Yeah.
Thank you so much for letting me speak, and thanks for to all of Climate Health Now for being some of the wind beneath my wings.
Absolutely. It's an honor. Gives me
Right.
goosebumps actually.
All
Thank
right.
you. Good
Thank
luck
you.
with the next talk.
All right. Bye.
Bye. Wonderful. And we'll talk about more about the HHS pledge. It'll come up, I would guess, through the through what Dr. Pevic will talk about. So then we kind of jumped into some content and how one person could make this amazing, step forward and kind of organize and find colleagues who shared her values. So really inspiring. That's such a great example of what Climate Health Now is all about. But we want to go backwards for a second. And if there's anybody who, let's see, if there's anybody who is here for the first meeting, we would love to welcome you. So if this is your first community meeting, if you want to come off mute, say your name, if you want to share your pronouns, what type of work you do or have done or are training to do, and then where you live and work would be fun. So is that Carmen? Yeah, do you want to, I think you've been on a different kind of a meeting, but if you want to say hi, we'd love to welcome you. Oh, wait, you're on mute.
Carmen from Napomo. I am a retired nurse practitioner, public health nurse, RN, and I'm currently working on some environmental issues in my community. I'm glad to be here.
Yeah, and Carmen got us a meeting with Senator Laird last month, which was totally awesome. So
that was awesome.
Applause for that. It was. Let's see. And then Matt Mulroy, is this maybe your first meeting? Do you want to say hi? You're welcome to.
Hi, I'm Matt. Sorry I'm late.
No worries.
Yes, this is my first meeting. I work at UCLA Health as a geriatrician, and I'm interested in all things climate and health related. Thanks.
We share this. Welcome, Matt. Glad you're here. That's great. And what about Keegan? Is this your first meeting, maybe?
Yeah, I'm new. I'm Keegan Bowers. I'm a KP pediatrics resident in Oakland. We actually just talked a couple days ago, Ashley. Yeah, I've been meaning to get in touch with you guys for a while. I've been really excited about working for some climate change stuff.
Cool, cool. We're glad you're here. You said you're a pediatrician?
Yes.
Awesome. Good. And then Michael Kahn, is this your first meeting?
Thank you. I'm here in Los Angeles, Santa Monica with UCLA, where I'm a lecturer, and I'm a bicycle advocate, and I'm struggling to get the health systems involved in transportation conversations, and I think that's a very important area where we perform very poorly. And I see Michael here, Rodriguez, where we met before, but there's much more to do. Let's get together.
Cool, cool. Welcome. Good. Anybody else here for your first meeting with us? Community meeting? All right, we'll bring all your friends, so anybody in health can come to the next meeting. We'll share the save the date later, but we're glad you're here. So yeah, we have a monthly meeting and lots of educational stuff in between. So glad you're with us. So now I get to introduce Dr. Bill Pevic, who is here as the representative from CHN's Healthcare Sustainability Resource Team. It's funny, actually, for those of you who know Pedja Stojic, who's one of our mentors on the organizing side especially, he ran into Pam Lee at the infectious disease conference happening somewhere. He ran into her today, so that's why she's not here with us. But we're in good hands with Dr. Pevic, and I'm going to turn it over to you for teaching us. So the floor is yours, Dr. Pettick.
Thank you, Ashley. If you could get to my first slide, please. Seeing you've got control. So Ashley and Amanda asked me to talk about carbon emissions and pollution from U.S. healthcare, and then also talk a bit about the fellowship that we're launching. So we're first going to give a little background. If I have the next slide, please. So as Lori mentioned before, the healthcare in the United States accounts for about 8 to 10% of the total domestic greenhouse gas emissions. And that adds up to about 1.9 tons of CO2 equivalent for every person in the United States just from healthcare alone,
Wow.
which is the highest per capita healthcare associated greenhouse emissions basically in the world. And based on what data, a little bit old, but data up to 2018, that per capita emissions total continues to increase. It's kind of staggering. The emissions from healthcare alone in this country are greater than all of the emissions from the entire United Kingdom. Next slide. So we're a big part of the problem. And those of you who have heard me talk before have seen this slide before, but I think it's important to go over this again, and particularly if you've not heard this before. When emissions are talked about pretty much from any industry, not just healthcare, it's basically divided into 3 scopes. And the first scope are emissions that are produced on site at the facility. So for a hospital, that would be on-site energy generation, which can be minuscule in some hospitals. My place, we've got an on-site gas-powered electrical power plant. So we basically make all of our electrical energy. So scope 1's huge for us. But for every place, it's the fleet vehicles, and another factor are anesthetic gases. And then scope 2 is the energy, scope 2 is the energy that is purchased from a municipal supplier. And scope 1 is only about 17% of the total, and scope 2 is only about 12% of the total. So the elephant in the room is the scope 3. So about 70% of healthcare emissions are embedded in how we do work. So a little less obvious, but clearly the biggest proportion. And that includes the stuff we use to take care of our patients, our devices and our equipment, our pharmaceuticals, but also involves travel, both for business and for commuting, both for our employees and our patients, disposal waste, which turns out to be a big problem, and food acquisition and food disposal. The next slide, please. But it's not just greenhouse gas emissions. U.S. healthcare does a lot of air pollution beyond carbon dioxide, accounts for about 9% of the total national air pollution, 12% of the acid rain emissions, and 10% of smog forming emissions. So just like we're about 10% of the carbon, we're 10% of all the other garbage that goes into our air. And it's been estimated that that pollution alone accounts for about 500,000 disability adjusted life years lost every single year. So we're supposed to be taking care of people, and we're leading to significant loss of life. Next slide, please. But it's also not just emissions into the atmosphere. Healthcare in the United States is incredibly wasteful. The average hospital generates more than 4.7 million pounds of waste every year, which works out to 6.5 tons every single day. And a big medical center like the one I worked at, UC Davis Medical Center, 17 tons of waste every single day. Every time I don't need to do this anymore, but the first probably 20 times I presented this, I had to go back and check because I couldn't believe that that was right. That's a daily total, over 450 tons a month. It's just staggering. And not only a staggering amount of stuff, waste that we put into our environment, we waste an awful lot of the healthcare dollars. Almost $6 billion is spent just to manage medical waste in 2014. Next slide. So that gives you some idea of the problem. Where can we as healthcare providers have an impact to try to change some of this? And I'm going to just give some examples because I think that's frequently a problem for us is what can we do? Where can we start? And if we're talking about this fellowship, you may not have any ideas, but I just want to spark some imagination. For scope 1, we talked about anesthetic gases are part of the scope 1 emissions. They're greenhouse gases that we produce and emit on site. And the volatile anesthetic gases are potent greenhouse gases. So if we give with carbon dioxide at a value of 1 for its global warming potential. Sevoflurane, isoflurane, and nitrous oxide are 2 orders of magnitude greater, hundreds of times greater than carbon dioxide. And desflurane is 3 orders of magnitude greater than carbon dioxide. So next slide. So one thing that is fairly easy thing to do is you can get desflurane off your formulary. And the reason it's kind of easy is not only is it really bad for the atmosphere, but it's really expensive and it's really a niche drug for anesthesia. So at our place, it was pretty easy just to get that off the formula. So that's not a bad place to start. But another area is to decommission the central supply of nitrous oxide. So if you work in a hospital that's not been built within the last year, on pretty much every wall of every patient room, and certainly in your procedure areas, there are 3 outlets, one for air, one for oxygen, and one for nitrous oxide. You go to next slide, please. And Brian Cheesebro from Providence, okay, back up. I'm sorry, I'm one ahead of myself. And go back to the next slide. I'm sorry, I need to back up. I told you that desflurane is a much more potent greenhouse gas than nitrous oxide, but this is data. These are data from Practice Green Health, and because of the volume of nitrous oxide that hospitals procure, about half of the total carbon emissions from volatile anesthetic agents is from nitrous oxide. So nitrous oxide is a big problem. Next slide, please. So Brian Cheesebro from the Providence system in Oregon is the one who's really brought this to attention. And if you look at that graph there, these are data from the Providence hospitals on nitrous oxide. And the total bar is how much nitrous oxide was purchased. The gray bar is how much was used clinically. So basically, the vast majority of nitrous oxide that's purchased never goes in a patient and ends up leaking into the environment. And they did a bunch of studies showing that everywhere in those centrally set up systems that nitrous oxide leaks at basically every different connection. We did our own audit at our hospital, and we found that we only use nitrous oxide in about 4% of anesthetic cases. We use about 31,000 liters a year, but we were buying 1 million liters, which means that we're only using about 3% of what we purchased. So 97% of the nitrous oxide is potentially leaking into the atmosphere. And next slide. So what we did, and this turned out to be surprisingly easy, we basically decommissioned our centrally supplied nitrous oxide. So we got a committee together with environmental health and sciences, environmental health and services, and environmental health and safety, excuse me, and several other stakeholders. And basically, we put plates, we took off the valves for the nitrous oxide, covered them up. We turned off the valves at the at the junction points, and we disconnected the H cylinders, which are the big cylinders for the central supply, and converted all to these smaller E cylinders, which can just be put on the back of an anesthetic cart. And what we found when we did this in March of this year, this slide shows our purchasing of nitrous oxide. And we were purchasing, I don't know what the units are on the y-axis. We've basically gone to purchasing 0 in 2023 since we implemented this. And we'll probably go well into the next fiscal year before we need to buy any based on our analyses of how often these e-cylinders are going to need to be changed. To the next slide. So another area where we can have impact is in energy efficiency. And this is both scopes 1 and 2 if you make on-site energy, or all scope 2 if you buy all your energy. And there's lots of different options to increase energy efficiency in the hospital, particularly by decreasing energy waste. So one option is to turn on setbacks of your heating and air conditioning when units aren't being utilized. That's actually a big problem in operating rooms where they do multiple air exchanges every hour. It turns out you can turn those down when the rooms are empty and really save a lot of energy. You do a similar thing with occupancy sensors or timers for your lighting and your heating in basically all your buildings. Convert your lighting to LED lights, which use a fraction of the electricity of standard lighting. And this can be a little more difficult to do, but you can, if you can try to set all your clinical computers to be turned off when they're not being used, or when all those computer monitors and computers that are in all these offices and so on. And I don't have those numbers in front of me right now, but the potential savings from that alone are substantial. Next slide, please. And then finally, where another place we can have an impact is scope 3. And as I mentioned in that earlier slide, 70% of healthcare greenhouse gas emissions are of scope 3. And seeing this is how embedded in how we work, clinicians and healthcare providers have the greatest potential impact to change scope 3, because we're the ones who know how we do work, how we do business, and where the opportunities are. So next slide. So one area that is frequently overlooked is just how we practice. We think about getting rid of chemicals like the anesthetic gas. We think about reducing waste and buying less stuff. But if we think about our practice patterns, so the waste all happens when we take care of patients. So if we can do more preventive care and have to do fewer interventions, do fewer admissions, we'll back up, please. We can save a lot of resources, a lot of energy. And also we can be more efficient. There's all sorts of redundant, wasted studies. We repeat radiologic studies. We order extra medications that get lost. We open stuff that we never use and just throw it away. So if we get it more efficient in how we practice, we can have significant environmental impact. Next. And another practice change is being very thoughtful about how we prescribe medication. So this slide, this graphic here is from the Eckelman article, classic article of 2020 on healthcare emissions. And this is looking at scope 3. And you can see pharmaceuticals are a big chunk of the scope 3 emissions. So if we can be more careful how we prescribe drugs and don't give wasteful prescriptions, we can have significant environmental impact. Next, please. Another option, and this is a broad option, is reducing waste. So waste is a problem because we produce so much, as we mentioned earlier, but every product that we get has got a life cycle. So resources have gone into making those, energy has gone into making those, energy has gone into distributing those. And so every time we throw something away, not only do we contribute more contaminants into our environment, but we also are wasting lots of resources and lots of energy. So things we can do are we can replace disposable items with reusable items. We can be more thoughtful and only open stuff we need. Don't open 3 things in case you need them when you probably only need 1. Reprocessing is an option, and that's a whole nother discussion, but it turns out there are lots of items and devices that are labeled for single use that are really not any different from their multiple use predecessors. And there are FDA approved companies that actually can reprocess those instruments so we can use them again at a much reduced cost. So it saves money and is environmentally friendly. We can be very thoughtful about our waste segregation. So the red bag waste, the contaminated, somewhat hazardous medical waste that goes into the red bags is bad for the environment because it gets trucked to an autoclave and gets autoclaved before then being trucked to a landfill. So you have increased transportation and lots of energy for steam and heat to autoclave them. And we can also be careful and try to recycle everything that we can. And the last thing that can also be a relatively easy thing to make an effort on is decreasing all the paper, all the wasted paper that we mail to people, hand to people, that most of that stuff can be done digitally now. Next slide. And then the last thing in scope 3 that I'm going to address is food. So I checked with our kitchen, and at my medical center, they produce 6,500 meals every single day. That's between meals for staff and patients. And if you know anything about the environmental impact of food production, it's probably the biggest factor for the environmental problems that we're into. Huge amount of greenhouse gas emissions, the biggest cause for biodiversity loss. The biggest 70% of freshwater use is for agriculture. Meat production in particular is very bad for the environment. So things that we can do with our food services is we can try to source our food locally. So we decrease the cost and the greenhouse gas from the distribution. Can try to decrease the meat on our menus because meat is such a bad actor. And it turns out 30 to 40% of waste of food produced in the United States is wasted, and hospitals are part of that as well. There are programs where edible excess food can be donated, and anything that is not edible should be composted rather than just put into landfill, where it then produces methane and has an even bigger negative environmental impact. Next, please. So that basically is a little primer on the problems with healthcare and some potential opportunities for us as healthcare providers. So the next question is, how can we make an impact? We have some ideas of what we can do. How can we do that? So next slide, please. So Climate Health Now has started a healthcare sustainability fellowship. And what this is, it's a structured program potentially to help you enact true, real, concrete changes to make your workplace more environmentally sustainable. So anything you might do is probably not going to solve the climate and environmental problems that we have, but all change is incremental. We've got to start moving the needle. We can't just talk about this stuff. So the goal of this fellowship is to really help our members make a change and start getting things moving in the right direction at their workplace. Next slide, please. So at the beginning of this month, pre-application process is open, and we're going to be accepting pre-applications until Halloween. And it's a very simple application. We try to make this easy for you. We just want to know what your project is, so the project title. We want you to identify what is the current practice that you're hoping to change. We want to know how we plan to change it, what the proposed intervention is, and then have a brief idea of how you're going to measure the baseline and the outcome to make sure that you've actually made a difference. And that is the link to the application. Next slide. This fellowship is tuition-free, and it's open to any member of the California healthcare community. So you don't have to be in any profession. You just have to be associated with healthcare. You don't have to be a member of this club. Anybody who works in healthcare in California is welcome to submit and encouraged to submit. You can submit a project on your own, although we would prefer a team. Just from our experience in doing on these, those of us who've done these projects ourselves, it's much more effective. You have to have a team to get this done. So you can do it yourself and get your team to help you do it. But if you have a team working on it on the application, that will be preferred. Next slide, please. So these pre-applications will be assessed in after they're at the beginning of November, after they're submitted. And the criteria for approval are going to include feasibility. Is this project actually doable? Impact. Is this project actually going to have a meaningful change? And probably a lower, but still important, is this something innovative? Is this something that we haven't already thought of or others haven't already thought of? That would make it even more powerful, because you come up with a new idea and you can take it to success, then we can share that with other people and we can all find a new avenue to make some progress with this in this area. Next. And so we think we're going to accept up to 4 applicants to submit a full application early November, where there's only so much bandwidth, how many fellows we can have. If we get a whole bunch of applicants, which would be wonderful, there's potential we will take more, but right now we're anticipating taking up to 4 applicants who will be then invited to submit a full application. The full application is going to include much more details, very granular, how you're actually planning to do this, and those will be due by the end of November. We anticipate that the fellowship will run from January through December of next year. We plan to meet at least monthly to help guide you on your project. The opportunity will be there for any ad hoc meetings as needed. I'm a retired guy, and I've been working in this area for about 3 years at my own health center. I am very happy anytime to help anybody with the project. If you need me to go to your site and meet with your procurement office or meet with your officer or meet with your CEO or your department chair, or whoever it is, and share some of our experience or give you some data, help you find data, I can do that anytime. So we're going to meet at least once a month, but potentially more frequently as needed. And then the hope is that each fellow will have a successful result and then be able to present their baseline and their final results at one of our CHN meetings in early 2025. And just as an added caveat, this obviously takes a lot of effort and a lot of work. And very few of you have the luxury of being retired like me. So you've got day jobs and you're going to try to do this. But don't try to get co-benefits out of this for yourself. If you're in an academic institution, try to set this up with, you make sure your IRB approves it, set it up such that your data are collected, that you could write it up as an article for a journal publication or a presentation at an academic meeting. And if you're not in an academic center, many, if not most of us, have opportunities to present QI, quality improvement projects, at our workplaces. So use it to write up a quality improvement project at your institution and get more out of it than just presenting it to Climate Health Now and have the satisfaction of making your workplace more sustainable. So I think that's it. And I think it's time, hopefully, for some really enthusiastic questions.
And a welcome to Dr. Pam Lee, who's joining us during the conference, right, Pam?
Yes, I am at the coolest conference in the US, ID Week. So it's a big party. Just letting you know, I've had one glass of wine and I'm ready to go to sleep. So that's how hard we ID folks like to party. But yeah, thank you, Bill, for taking the lead on this presentation.
I love it. I thought you were going to say ready to have fun, but thanks for being here with us.
Okay.
Yeah. So we there was a lot there. On a round of applause for Bill. That was great. Really, really great overview. And like a perfect segue. You know, here's a major problem, and we've got this awesome team who's ready to support you if there's something that you want to work on at your workplace. So we have what questions are there? We have lots of time for that.
So there's a lot in the chat, which if I look at, I'm not going to be paying attention. So, I mean, I don't know if there are any questions, but there's a lot of comments.
Ilana, I missed the emails. Can you go back to the slide? Oh, for the emails of Bill and Pam? Is that what you meant? Yeah. Maybe Amanda, would you be able to help with that? Because we can do that. What other questions? I see Vanessa.
So I just wondered, the issue of the red bag waste. Is there any other option besides, taking that to the landfill? I mean, finding out what's reusable. And I think a lot of people just use that red bag when it's inappropriate, and I think some of that medical waste has ended up in our ocean somehow. So yeah, just wondered if you had any insight on that.
Yeah, nothing from that. It actually has to go in the medical, and the red bag waste can be recycled or repurposed. So that is an absolute no-no. You get a huge fine if you try to do that. After it gets autoclaved, your options are landfill or incineration. So neither are very good. The problem we found when we started our red bag waste reduction effort, UC Davis Medical Center was an outlier from all the 5 UC health systems. We generated more red bag waste than all of our sister institutions, and we're way above the industry standard, which is about 9 or 10% of your waste stream should be the red bag waste. So we did a 2-pronged effort. One was education to make sure our folks knew what went in the red bags, but even more importantly, what doesn't go in the red bags, where there's a lot of misunderstanding of that, a lot of overuse of those. But the next thing is to make those red bags less convenient. So for instance, with our previous setup is we had a standard trash bag in every patient room, and right next to it, a red bin that was typically the same size, right next to it. And people used it indiscriminately and used it as an overflow, particularly for all those disposable isolation gowns. So we took those bins, those trash bins, out of the patient rooms and replaced them with a small wall dispenser of red bags. And so if the nurse or the doctor or the student or the tech thinks they're going to make something bloody, they take a red bag out, put that material in there, tie off the bag, and carry it to the central dirty utility room. And things like that. So in places where you generate more bloody stuff, like operating rooms, procedure rooms, where you put your bin, where you put them, you don't put them right next to each other. You need to put it in a corner where you have to actually consciously think to get something in it. those kind of things can really change behaviors. And we reduced
Wow.
our red bag waste by 40% with those efforts. And we
Yeah.
still haven't rolled out the reduction areas to the biggest
Wow.
places like the OR. We're just starting on the OR now. So we'll probably reduce them probably another 10%.
Yeah, I don't know. So
Great.
Keegan
Thank you.
here at Kaiser, and yeah, good question, Vanessa. And Lila here at Kaiser, we got a message from our executive basically saying Kaiser's paying multiple millions of dollars for screwing up our waste streams.
Wow.
And I think your point about the need for education is enormous. Can I ask a question?
I just want to add to that. That is a big problem. So, and that's something we're facing now. We're rolling this into the OR. You want people to be so good. I'm not throwing anything in the red bag waste that then you start putting contaminated stuff in the regular waste, because yes, you are potentially, in addition to spreading disease potentially, you're potentially going to get huge fines. And that's what happened to Kaiser. So you have to be very thoughtful in how you do your waste segregation.
Yeah. Could somebody who wanted to work on the financial investments, like if there was perhaps a health system like Kaiser who still invested in fossil fuels, could that be a sustainability project?
You asking me?
Yes, or Pam, as the bosses.
So can you phrase the question again for me? I actually was looking at the chat.
So as I understand it, the investments of a health system go in scope 3. And so I'm curious if there was a group who wanted to work on getting their health system to divest their investments from fossil fuels investments, could that be something that they could apply for the fellowship for?
Absolutely, I think.
Right.
Yeah.
Cool.
And that is something that should be considered, right? It's not necessarily something that we think of naturally, because I will say until I started learning about this space, that would just never have occurred to me. But it is something, and I think it also shows an administrative commitment, right? It's kind of putting your money where your mouth is too. So I think that would be a great project.
Mm-hmm. Mm-hmm. I see Alana. Welcome.
Thank you. That was such a great presentation and great outcomes. And I love how scope 3 is like more accessible to, it's like a great starting place for your average person, and you can start individually and you can talk to your coworkers about it. But the other things that you accomplished at UC Davis are huge. And I was just wondering, as you were talking through it, it's like, where do you even start with something like that, like changing the anesthesia and the canisters and all of that just seems like such a huge undertaking. I don't even know.
Yeah.
I'd love to hear some details about like where you would start with a project like that and how the next person could do similar things.
That's a really good question, and probably could spend an hour or more trying to answer that. And that's what the fellowship is for, to try to help you figure out how to do that in your own environment. Each project that I've been involved with has happened a little bit differently. I can tell you how I started by giving what I thought was a very frightening grand rounds presentation, not on medical stuff at all, but just about all the environmental challenges we're facing, not just climate, not just carbon in the atmosphere, but waste and loss of biodiversity and the problems with agriculture and nitrogenous runoff, overpopulation, food production, plastics pollution, and started using that to help find some like minds. And so got a group of professionals, not doctors, nurses, medical students, some administrators who were interested in this. And the first thing we did is we did a landscape assessment. We all said, we said, okay, what do you want to work on? We had like 10 different ideas. And we sent everybody out to find out what was already being done on what they thought their cool ideas were. And all of us were surprised to find that a lot of times there was already stuff moving in the right direction, where so you could just nudge those things along. Some we were so far ahead with sustainable food procurement that we didn't even bother making any efforts on that. But other things, there was nothing going on. And then you need to analyze the problem, figure out who the stakeholders are. So you talked about nitrous oxide. It helped that we had an anesthesiologist who's very interested in this, and she had heard from Brian. bro, and she brought that back to us. It really helped that her chairperson, her chairman, was really backed us up. And it really helped that we found a guy who was in environmental health and safety who just picked this up and ran with it. So we got this done in a few months, primarily because Albert was just, he was phenomenal. But you know, most times you need to do a cost assessment. You need to figure out what you're trying to change, how much it costs, what you're trying to switch it for a cost. So you need someone for procurement to help you with that. You need to look at the logistics. So whether that's environmental services, materials handling, you just need to just analyze what your problem is and find the right stakeholders and just try to engage them. That's my long,
figure out what our problem is. Very, very deep, Bill.
Yeah.
Is this a good time maybe to just mention, because I don't know how many health systems have a carbon inventory, or has anybody else heard of a carbon inventory? Because that, I think of that as like the map, right? That's what just got passed on a macro level by Senator Wiener, that's requiring businesses over, I don't know, $1 billion of revenue in California are going to have to start doing carbon inventories of their businesses. And so their scope 1, 2, and 3, they're going to have to start measuring, and then they're going to have to start making that public. And the way I think about that is it's kind of like a hot map, and I've seen the one for Kaiser, and a big chunk of scope 3 is the pension, and so that, to me, that's what can help guide where the highest yield efforts could be. So not all health systems have it, but like Bill showed, there's, for healthcare, there's sort of the themes which could help inform where to start, to your question, Alana. Maybe we have like 1 or 2 more questions, and then we have even more cool content before everybody departs for dinner or whatever. Yoga, whatever. Ashley does always have context in mind. You know it. Too many. And then I wanted to just say a welcome. I see, is it maybe Abby joined in, and Janet and Daniel. We're glad y'all are here. Yes, Lila, I can share that with you. For sure. 1 or 2 more questions. I'm really grateful for y'all. I really appreciate this community and this conversation, because it's great to have a community to talk about this stuff. Okay, well, don't all send in your application at once. We don't want to like break the form, but do send them in. So like Bill said, you have this month to think about it. Maybe find a partner at work or something to say, hey, there's this opportunity. Don't you hate the fact that we have, whatever thing that bothers you, the pebble in your shoe? That also could just be a way to focus your efforts, is like, what is it that drives you nuts about what you see at work every day? And I would also say, and I think Bill and Pam, you'd be open to this, is like, we put your contact info in the chat, and maybe somebody here, kind of wants to brainstorm with one of you of like, I'm not sure about a project. I don't know. Could we even just talk about that, like what a project could be? And I think, am I right, Pam and Bill, you'd be open to just brainstorming? Yeah. Awesome. So thank you so much to both of you for visioning this, and also we'll do a shout out to Shuwen Cheng, who gave a lot of great ideas to this project also, and we're really excited for what could come out of it, and the learning we will all gain from each other. So I guess I'm going to go back to sharing. You ready for this, Amanda? Okay. So we've got a legislative update before we wrap up.
Yes. Hi, everyone. Can you hear me okay?
Uh-huh.
Okay. And I am coming to you live from clinic where I didn't bring my laptop charger, so I'm hoping I can get 10 more minutes out of my laptop. Bill and Pam, thank you both so much for all of the work that you do and for all of that information. It is astounding. So thank you. We wanted to just give an update on the other big arm of what Climate Health Now has been up to, which is our 2 legislative campaigns. So we have good news and we have not so good news. The good news is that one of the two bills that we worked really hard on this past legislative cycle was signed into law by Governor Newsom on Sunday, just this past Sunday. AB 579, which was authored by Assemblymember Ting, which mandates that all school buses purchased in California must be zero emission after 2035. And we worked with a really awesome coalition of different groups from industry, from schools, other health groups, to push that forward. And notably, that bill actually failed 2 years ago. It got vetoed. So this was a huge step in the right direction. The less good news is that the other bill that we worked on, SB 394, which would have mandated, or which would mandate that the California Energy Commission create a master plan for climate resilient schools in California, was vetoed the day after AB 579 passed, with the primary reason for the veto being the cost. So at some point we will have more information on that, and I think more opportunities to debrief, but we wanted to share that out. And then Ashley, if you could go forward. So what we really want to share with you all, and we'll share this all out in email as well, is what we did together on these two bills. So I'm not going to read through every single one of these, but the highlights are, we collectively as a membership got 3 letters to the editor published, 1 op-ed published. We spoke at a press conference in San Francisco. We were part of an ad that ran in the Sacramento Bee, a full-page ad in support of SB 394. Amazingly, we had 56 CHN members participate in 17 meetings over the course of 8 weeks with their legislators. And that was 56 unique people. I think we had a number of people who have participated multiple times and had closer to 80 participants, including the people who were in more than one meeting. We sent 133 emails to Governor Newsom in support of our bills, and we sent lots of other letters as well, including to Senate and Assembly appropriation chairs, also to Governor Newsom, and then we also authored 7 organizational sign-on letters that earned signatories from organizations like the California Medical Association, American Academy of Pediatrics California, and other big groups. So that is huge. And this was all from essentially April until October. So yeah. a big work of love right there. And then one more slide. Alrighty, we just wanted to shout out the specific people who played a huge role in this. We had campaign team co-leads, who are those people you see there, who did things like participating in coalition calls, working on health talking points. Mike Harris in particular really led the charge on letters to the editor and op-eds and did an amazing job there. And then the people below who stepped up in really specific ways. Knox spoke at a press conference. It turned out that Pasadena was a very pivotal place in the state for both of our bills, because both appropriation chairs have districts that are at least in part of Pasadena. So we were calling on our Pasadena members a lot over the last few months to really try to pressure those decision makers, and they really stepped up. So
thank you, Mark Rudernick.
Thank you all. Thank you, Mark Rudernick, who's on, and Hina, who's on or was on. So yes, more to come. But this is the first year that we have participated in campaigns in this way, in such a sort of planned out and concerted effort, and we are really, really proud of what happened and really excited to try to do this again and do it better next time. One thing I'm just going to mention now, something to look forward to. So we do this work through our 501c4, which enables us to do legislative lobbying. So one of the things we'll be launching in November is our first ever member fundraising drive, specifically to fundraise for the C4, to enable us to participate in more legislative campaigns, to train more people to do this work. So please be on the lookout for that.
Awesome. Thank you. And you want to do this one too?
Sure. Alrighty. So we will close it out by saying if anyone knows, hopefully we all know other members of the health community in California. We have a very broad definition of members of the health community. We welcome anyone who identifies as a member of the health community in California to join. So please spread the word. You can send people to our website, which has a join now button. I'll just put that in the chat. And then that QR code also works. We mentioned fundraising. Ashley, do you want to put the donation link in the chat? I don't have it right now.
I would if I could, but
okay, we'll try to get that in the chat.
Yeah.
We mentioned that we'll be doing a dedicated C4 fundraising campaign, but we are always looking to continue to fund our work. So if you're interested in donating or know anyone who might be, please spread the word. And last, go back one. Perfect. Last but not least, we will share the registration link for our November monthly meeting, which is going to be back at a lunchtime hour. I will drop that in the chat right now.
I think I did actually. Yeah.
Oh, you did. Perfect. Excellent. So November 8th at noon. And this is the first time, at least I think the first time ever we've ever done a monthly meeting in the evening. I don't know if most people consider 5:30 late afternoon or evening. But we're curious if, I mean, you don't have to say so now, but feel free to email us or message us or in any way, like what people thought of doing it at this hour versus lunchtime. We really want to find ways that work. We know there's not a perfect time, obviously. But we're curious for people's feedback on the time and how this does or doesn't work.
Yeah. Awesome.
Yeah.
Yeah. Thank you, Amanda. I really appreciate you telling the story because it's great to review, and it's just so many people contributed, which is really, really great. So that's it, y'all. That's our monthly meeting. We have time if there's a couple questions before the fire alarm drill goes off in my office.
Oh my.
Yeah, Michael.
One of the things I was thinking about with all this great advocacy and efforts that are being done to add to the mix, I wondered if you discussed much about local ordinances. Or working on on a city level, because you can work with city councils. You can sort of say, for example, where the city sort of acknowledges what their contribution to greenhouse gases are, and then there's a sort of an intention to sort of reduce them, right? So then that puts on government the responsibility of them doing something, right? I mean, so that kind of level of work, it's good because this organization is statewide. Everyone has in a different locality. I mean, there can be some some interesting and very powerful work in that way.
I would say, Mike, that is my dream, to get to the point where we have enough members that we can have people working locally together, bringing their health voices like to their cities, to their municipalities, 1,000%. We're not there yet. We need more people power, but that is the dream. That is like what keeps me, that's what keeps me going.
But maybe there's a few spots.
Yeah.
Because then that kind of thing could be, presented at a meeting, or kind of lifted up to the California crowd.
Yeah.
And so then that way it could kind of energize the base.
Yep.
Yeah. And Bill has spoken about that too. It's a lot easier to influence your city or your county than your state.
Totally.
And
Totally.
yeah, like Amanda said, that like 2025, we're hoping, but we just need to build some more leadership layers to get there, or we need to multiply all the people we have now. But definitely, we want to be able to do state and local or state and regional. But it's in the future.
Yeah.
on
We
the
got
path.
and we gotta fund our 501c4 too.
Also.
Yeah.
Yeah. Yeah. Awesome.
Yeah.
Well, we're gonna break. It was really, really good to see all your faces and to be with you. And thank you again to Bill and Pam for creating this fellowship and speaking about it and sharing the opportunity. And we hope you all apply and have a great evening. Good to see you.
Bye,
Bye.
everybody. Thank
Bye.
you.